Hi, everyone. Thank you so much for joining the sessions. This has been a very informative meeting, especially for me, because this is my first, SynGap conference, actually. And Monica has been very instrumental in getting a group of us, researchers, clinicals, scientists, as well as basic scientists together. You've heard from Julia Dahlman for the past 2 days, actually, as our zebrafish expert who really got me into this field. And so we wanted to talk about our new study that we're hoping we have some participation from the families of children with SYNGAP. And so we are going to talk about the app, patient reported outcome measures as well, that Dylan Baker has really helped us advance forward, which will make it a lot easier in recording these symptoms and everything. So I'm going to start by telling you why we decided to even start doing this study in the first place. So we do know that GI problems in autism spectrum disorders of any kind are very common, and that caregiver assisted symptom tracking can be very helpful. The symptoms that patients often feel, which they may not be able to verbalize, and we understand that, are abdominal pain, nausea, vomiting, bloating, reflux, regurgitation of food, having constipation, soiling, retching, and then dysphagia. We also know that in our field of neuro-GI motility, that gut-brain interactions are very important. In constipation, in reflux, and in abdominal pain in general, we tend to call this a visceral hypersensitivity when it's what we call functional GI disorders, which don't really have a pathophysiologic mechanism behind them. And then we call them motility disorders when there's actually something that's neurologic and physiologic that explains these symptoms. And oftentimes those can overlap. And we know that in ASD, the GI symptoms certainly can cause and aggravate behavioral problems. And these can be, socialization, language development, repetition, aggression, disturbances. And we see that in Parkinson's, we see that in other dementia diseases as well. So that's not necessarily just isolated to ASDs. In the general population, I think this is important that even in the general population, 25% of children actually carry constipation into adulthood. So constipation itself and by itself is actually a very common symptom that we hear patients complain about. And so why we decided to study gut motility in humans is because the gut and the brain axis are involved with a lot of these disorders that we see. Serotonin is a very important neurotransmitter that's produced in the brain, but there's actually 14 receptors for serotonin in the gut, and that impairs motility in the gut in our general population of patients who don't even have ASD. And immune function is very important. And all of these things require that the peristalsis, which we call the movement in the gut, it requires all of that to be normal in order for our immune system to interact with the gut microbiome and for the hormones to actually be produced and also function normally. So all of these mechanisms are involved in this thing that we call the gut-brain mechanism. All these have to be in order. And the GI tract, of course, has its own nervous system, which is the enteric nervous system that's very important to all these things. So in the general population, how we normally study gut motility and whether the nerves in the gut are intact is through several different tests that we have available. The first thing we do is we do a good history, obviously a good physical exam. We try to see what are the symptoms of constipation that are exhibited in our patients. So patients may report hard stools, and these are also the same with ASD, rectal bleeding, fecal leakage. So having incontinence, what we call in the medical field as fecal incontinence and leakage, can sometimes be due to severe constipation. Incomplete defecation would be someone who would complain that they don't necessarily feel like they go to the bathroom, but not everything's empty. They still remain bloated. They don't feel like they've had an adequate stool. And then pain in the rectum would be an obvious sign of possible constipation. Straining is a big one, and kids with ASD have a lot of straining that is exhibited, and mothers will tell us all the time. And then decreased stool frequency. what we do is the stool, we use the Bristol stool chart, which is here. We, you know, as gastroenterologists, we think of ourselves as the plumber. And if the plumbing is hard, right, the stool can't come out and patients will be straining, they'll be uncomfortable, and that can cause changes in behavior. So usually we describe type 1 and type 2 stools, which are over here. I don't know if you can see my mouse, but they're like sheep pellets almost. That's what we describe as constipation. And then type 3, um, 3, 4, and 5, those are normal. And then type 6 and 7 are diarrhea. And it's weird because you can actually have diarrhea and still be supremely constipated, because the stool that's around the hard stool, the cemented stool that's in the rectum, can come out as diarrhea. And so sometimes just because the patient has diarrhea type bowel movements, which are type 6 and 7, it doesn't necessarily mean that they are not constipated. So that's the reason we have the transit studies that we have. And then how we track symptoms normally, even in our clinic, is we ask patients to, again, tell us what their stool consistency is on this scale on a daily basis. And then these other symptoms that they record for us, they tell us the number of bowel movements. But when we see patients in clinic, it's very hard for us to go through like a month of this diary if it's on paper. And this is where things like apps are really helpful, because they will summarize the number of bowel movements and the frequency, and whether the patient had straining. If there's a change in medications, it's a lot easier for us on an app to be able to see that, what day that occurred, if that led to improved bowel movements, an urgency to have a bowel movement and things like that. So I think all of these things have become app-based for many of the other disorders that we study and many of our clinical trials. So mobile applications, they're great alternatives for patient diaries and collecting retrospective data. They show, research across a lifespan. So it's not just at one point in time. We can see if there's a variability in patient symptoms and if it, changes across. Multiple caregivers also can record events, because I'm sure times are busy and, mom or dad may be working at different times. They can be easily modified to reflect what is experienced by patients, because maybe we'll do this in ASD and we'll realize that we can't collect so much of the information because patients are nonverbal, and that can absolutely happen. And the caregiver may not necessarily know how to capture those symptoms. So this is where having a forum like a patient group and patient advocacy group and caregivers involved is really helpful for us, because we can modify as we go. And then the ability to perform objective gut function studies that can also be recorded has been very helpful. With COVID, obviously, we're having a lot more virtual meetings, and how we were setting up our study was virtual. So I think that does satisfy that pandemic issue. And then, of course, with SYNGAP and other autism spectrum disorders, we have patients and families that are all across the country, and there's not as many clinicians that could study these diseases in one location, and it would be difficult for caregivers to have to transport. So having a virtual option, I think, is perfect for this process anyway. This is a picture I took of Julia Dahlman as she was presenting yesterday when she was showing the app that Dylan Baker has provided us. And this is the app that's going to help the caregivers track GI symptoms in the children. And this is the screenshot from like what the beta version of the symptom tracker is. And so we've listed here the symptoms, the bowel movements, and you can just click each one. You'll see that there's a continue button at the end. And what that continue button means, it's basically you go to the next. So you go through checking which, is there pain with bowel movements? Is there a rush to the bathroom to have a bowel movement? Is there straining experienced? Are the children having black tarry stools? So some of it's very visual. And you can actually also pick on the app the Bristol stool scale, what number it looks like for the day. Does it look like diarrhea? Depending on the age group, it may look like diarrhea. And then reflux. So what are the reflux symptoms exactly? Are they seeing that the child is choking? Is the child retching? Are they seeing regurgitation or vomiting? And then pain. Pain is of course subjective, but they are able to assess what is the pain. The severity of pain is probably not really as feasible, right, on a scale, because if the child is nonverbal, that's going to be hard to capture necessarily. And then we are also asking Dr. Andreas to help us with the neurologic symptoms, perhaps seizures, if they're identified, that we can also record. And then if there's aggressive behavior over time, we will be able to perhaps correlate that with constipation and see if that is exactly related. And I think that would be an important endpoint for us to measure. So just to go over how we thought of this and why we came up with this crazy Smurf cake thing, because people will ask, like, why aren't you doing just the regular transit studies that we all have available? And some of it is on this, on the scale. These are all the measures that we have right now in the general population, how we measure motility. And the different tests are scintigraphy, whole gut scintigraphy. That involves an egg sandwich for patients to eat, and the egg gets marked with technetium, sulfur technetium, and that's what we follow through the gut, and we actually measure how long it takes to empty. Now, the limitation of that are that it is expensive. It's about $2,000, but most importantly, it's not the expense. It would be if the patient is able to even ingest such a thing, such a large meal. And also it does commit the patient to radiation exposure. And few centers have the whole gut scintigraphy. So Mayo Clinic, for example, and some really expert centers have it, but most places do not. Most places only have the gastric emptying study, which is the shortened version and only looks at the stomach. Then we have 6 marker studies. Those are a little capsule that the patient swallows. It has 24 markers in it. The patient swallows it and we count them through the colon. Now, the nice thing about the 6 marker study is the capsule is not actually, it's actually a normal size that a capsule would be. But the bad thing is it only looks at colon transit and it doesn't look at small bowel or the stomach. So again, you're just seeing one section of the entire GI tract. And then there is Smart Pill. Smart Pill is a capsule invention that was actually initially studied in NASA because they wanted to know if astronauts, what their motility is as they fly and what foods they can tolerate. And this is a capsule, much like the video capsule. The patient swallows it, and then on this receiver, we actually track motility contractions as it goes through the entire gut. So we see how it moves through the gut and if the muscles in the gut and the nerves in the gut are actually intact and they're working in the entire gut. The problem with this is for children, it's not.
So it's over?
And other tests are MRI that can be done. Those are defecographies, and that can be difficult for children to do, especially because they have to be in an MRI machine, expensive, even though there's no radiation exposure. And then there's manometry, where we actually insert a catheter into the rectum to see what the nerves and muscles, the neuromuscular function of the rectum is. Is the child retaining the stool? And really, in pediatric cases, we don't do it if they're less than 6 years of age, because it can be a little bit traumatic to have a catheter up the butt, even though they do bariums and they do enemas frequently. So that is something we pretty much limit to older children and then adults. But again, these are tests that we have available. And then lastly, especially for severe constipation patients, we have what's called colonic manometry, where via colonoscopy, we put an entire catheter through the length of the colon, which you see here. And then we look at these nice contractions that are beautifully demonstrated here on a color topography. And we see if we see these contractions, if there's neurogenic bowel, we may not. And there's multiple pediatric centers that actually do this test if we're thinking about removing the colon in a patient that has really severe neurogenic bowel. But again, these are just done in specialized centers. So the normal way that we evaluate how a patient digests is by gastric emptying scintigraphy. This is the meal that they're given. It's pretty nasty. Most patients, to tell it lightly, these are nauseous patients that we give these meals to. And it's, not the most tasty meal ever. But again, it's, technetium gets bound to this. We ask the patient to swallow it, and they have 5 minutes to swallow it. And then we measure how it goes through the gut. And you can see it on scintigraphy highlighting here. And the patient has to lay still, though, which is another limitation, for a 4-hour period. So this is a 4-hour study where every hour they have to be scanned. And you can just imagine any child would have, an adult probably, I'm too hyper for this test, would have difficulty for 4 hours laying in a machine. And then the radiation exposure is the other issue with this study. Then we have gastric emptying breath testing, and this is done with spirulina. And you guys have probably seen spirulina, right? It's a great digestive that's a prebiotic that's in many drinks and stuff right now. And this is bound to a meal that's also fairly disgusting. And then we obtain breath testing over time, and we measured the excretion of CO2 in the breath. This is FDA approved. In 2015, this was FDA approved for adults, and now it's going through FDA approval for children. However, in our North Carolina, ASD group, we did try to, and it's still a 4-hour test, by the way. We did try to get some children to eat it, and they were not going to have it because it comes in a powder and you have to mix it with this concoction. And it was not enticing for any of these children to want to do this, because this would be actually a very easy, non-invasive way. We even actually had approval from the company to give us like some of the kits for free, which was awesome because it's about $800, but none of the children wanted to even try. It just does not look appetizing. So it was not an easy way to do this. Anyway, then we found this paper that looked at using dyes in foods, like a blue dye, and then measuring that in the stool as a way of measuring transit. And so what they did is they fasted patients, they mixed this in a meal, and the patients ingested it. These are patients that actually many of them had ostomies, and they had what's called short gut syndrome, where they had diarrhea. And so they used this blue dye in the food to measure from hour of ingestion to when they saw it in their ostomy, how long that took, and they took that time frame as their transit. So we thought this was a workable test, and anyway, we decided to incorporate it into this baked item that has exactly the same amount of carbohydrates, protein, and then also sugar and egg white, which is very necessary for these tests, as the scintigraphy test. So we basically tried to look at the scintigraphy, what the components were, and really like create the same parallel thing, and then have a blue dye that was inserted into this meal with the same calories total, again, the same number of fat as well, to measure mouth, to basically defecation, so exit, right? So this muffin, right? So the Smurf cake muffin is ingested. And then we did have a couple of our patients, not necessarily patients with autism spectrum disorder, but a few did join us. And we looked at their, transit, looking at the level of GI distress, and saw if we can actually evaluate these patients' transit. They recorded for us when they ingested it. They recorded it when they first saw the first blue stool or green stool. In some patients, it's green, and some it is blue. And then they told us when the last poop was basically green or blue. And then that's the lag time that we can actually measure. So to tell you guys about the actual study, we need basically anyone who's interested in joining us. An app, the symptom tracker app, will be provided at no cost. The cost would be, hopefully, if we can find somebody that can bake this Smurf cake, that will be a lot easier. I think Julia had a lot easier time than I did making this myself. I'm not a baker. And then, adding the blue dye into it. So I think if you have children, then it probably is easier because you're used to baking cookies and all sorts of stuff for school. But really that the cost of making that is the main cost of this study. We need to be provided if interested, and if the caregivers sign the consent, we need a shipping address. Once we have a baker that makes them, we are trying to still look into that. If we can find a baker that will just ship this to you guys, that will be a lot easier. And then we will record a time where we will all meet in a virtual meeting where we want to really videotape the children as they ingest this. And so we can really guide you through the study, the app, and how we're going to track all these symptoms. Again, that will be provided at no cost. And then the caregiver will be recording the time at which the stool is blue or green, and then the time at which the stool is no longer blue and green. So the last stool where they saw the blue-green stool. So they will have to record every bowel movement until the last bowel movement is blue and green. And that will tell us how long it takes for the dye to empty, and that will tell us about gut transit, right? So it'll tell us from now. Now, if a patient has a feeding tube, unfortunately, we will not be able to do the study. So that is a limitation. I think at some point we can modify it, but for now, because it certainly can go through the G tube, but we want to first just study the patients without feeding tubes. And then, of course, participation is totally voluntary, and all of the data is going to be confidential. The inclusions are patients that are age over 2, so 2 and up. Any subject, again, without a feeding tube, we'll get the consent from the caregiver. We would love for healthy siblings, if they can be also available that day, because I think siblings are the best control group, right? For our patients, I mean, parents could do it too. I've done this muffin, and Julia and I have sent each other our stool pictures when we did it, because we were testing it. And, you know, so if you have a healthy sibling that would be willing to also do it at the same time, it may actually motivate, I think, your child, but if not, that's okay too. At first, I think we will have to ask the caregivers to prepare the meal again, unless we can find a fantastic baker that's willing to do this for us. And then any allergies to any component of this meal, then of course the patient cannot do it. We have provided some substitutes that can be done. So I think that will make it a lot easier, especially if there's, for example, an egg allergy, and then the child has to be able to obviously consume the meal. So it has to be the size of a meal that they're able to actually ingest. So if you guys are interested, please contact us. And this is my Gmail account, mostly because I'm afraid if you sent it to my university account that it will get spammed, because everything does nowadays. So this is like my Gmail account. If you are interested, even just hearing more about the study and what it is, you know, feel free to contact us, probably for the first virtual. So we have IRB consent and approval for a year, and we're trying to see if we can recruit some patients and get some preliminary data this year, so that we can, you know, then have maybe better studies or sort out the app and see if the app is actionable, and if it's, you know, if it can be done. Now, that study won't just be done in SYNGAP. This will also be in other autism spectrum disorders, so Phelan-McDermott syndrome and others. But I think it would be nice to have the same genetic mutation, if we can, as many patients as we can. So I really appreciate you guys giving us the time to present this, and special thanks to the SYNGAP Foundation, I don't know, the Bridge the Gap, and then all the families and affected children. Monica has been really instrumental in getting us involved. She's a superstar, and we really appreciate all of the support that she's given us to try to help us advance this forward. Thank you so much. So I hope you guys can hear me, so we can ask questions.
Yeah, does anyone have any questions for Dr. Moshiri?
I do. Can I speak? Okay.
Yeah, go ahead.
My name's Julie Michigan. I have an 11-year-old son with SYNGAP. He doesn't have a gluten allergy, but we have kept him gluten and dairy free for various reasons. And we've tried over the COVID shutdown twice to reintroduce gluten, and it could have been a fluke, but it did change his stools and his behavior and sleep. So seizures. So we took it back out. Okay. Is there a gluten-free alternative if he wants to do the study?
Yes, we actually did it gluten-free because of that, because I know a lot of
because it said flour, so I wasn't sure if that meant wheat flour.
Yes,
it's gluten-free flour.
Gluten-free flour, yeah. So we'll have to better define those parts, but yeah, it's gluten-free. So we will have that. We will have to have that as an option, because that situation is the case for a lot of patients and caregivers. Yeah.
And then one other question: if his twin has Crohn's, but it's completely controlled with like a biologic, does he count as a healthy subject? Like
probably
to do the
not, probably not, but it would actually be okay to have another disease process even. and that we can do, but we'll have to know that. We'll have
Okay.
to know that, but we won't be able to count that as a normal control, because even if normal and healthy and controlled in remission, then it could still, it would not be counted as healthy,
Okay.
in a further data.
Thank you.
Sure.
Can I ask just quickly of Julie, how, when you say gluten-free, are you completely, like, do you keep your pan separate and everything? Oh, well, never mind.
That's a good question.
Oh, Julie on mute.
Oh, Julie, yeah.
I'm sorry, can you repeat the question? My husband was asking me a question at the same time.
No problem. I was asking, so one of the things, we have been looking for bakers who can provide the Smurf cakes, but one of the issues that friends of mine who have gluten allergies have raised is that there are different levels of gluten-free. So there are some bakers that completely, like, the oven doesn't see wheat, the pans don't see wheat.
Yeah,
So
he's not at that level of, I mean, we throw everything in our oven and he's probably gotten soy sauce that has gluten. I mean, it's just more like we keep like chunks of it out, and I'm happy to try to bake them. I mean, we bake stuff in my house. If like we need to bake one, we can do that.
Okay.
Because we can provide the recipe. And
Can I ask a question real quick?
Sure.
So you mentioned, Dr. Dahlman, that you were looking for bakers that would be, do you need someone that is like, that will bake just completely, does not do anything with gluten? Would something like that be more helpful than someone who does both, to kind of protect that population that has to stay gluten-free?
that would be preferable.
Exactly.
Okay.
Yeah.
Okay.
Yeah, it definitely cannot be an ordinary baker, because we've put a lot of substitutes in there. They have to be able to understand allergies.
Right. Okay. And about how big of batches, or what are you looking for? Do you know yet how many you're going to need?
Well, for the that's a good question. It'll depend on the recruitments, but
Okay.
hopefully the more the better. But and we're willing to pay them for that, of course. But
Right.
yeah, we'll see how many we are able to recruit, but we'll probably send them enough for their healthy sibling if they have one. And
Okay.
here's Julie anyway, just to see, just for our own input.
Okay. Thank you.
Yeah. Thank you, Leslie. If you know someone, let us know, or anyone.
I'm going to put some feelers out.
Okay. Yeah, and
I
then
have a question as far as preparing the cakes themselves. Are you using ingredients that we can find like a Cub or Target, or do we have to go to specialized stores to find these types of ingredients?
yeah, most of the ingredients we were able to buy some of them from Amazon, some of them from like a Whole Foods. So I think they're not difficult. We can certainly share with you guys if you're interested in even seeing what is on the recipe. But yeah, it's not difficult to find the ingredients. I hope that answered your question. And Dylan is actually on the call. So I don't know, Dylan, if you have anything you want to say about the app. I tried to describe it as best I could, but I'm terrible with any technology.
Oh, you did a great job. Thank you. I think you pretty much covered it. Basically, the thought process was, in the time of COVID, we really need something that can be remote. So it's just like we want to be able to get good quality data without having people need to go places or keep track of stuff on a piece of paper, because that's obviously not ideal. So it's basically just a resource to try to help with data tracking, and especially this study.
Yep.
It's fantastic to have an app that you can use for
I
this.
think it would be nice to have something that's tangible and can be converted into a database, because Dylan's talking to a lot of people. Of course, it's going to be all secure. He's really making sure everything's like very cyber secure, or so that the data is not going to be shared, and all of that, obviously important. important types of things. All
Does
right.
anybody
So
have any other
anyone else have-
questions?
Yeah, any other questions? Any questions about what I discussed even? If it's about, you know, how we study gut motility or, you know, others.
Yeah, I guess I have a question. Does the composition of the microbiota in the gut, is that at all impact the transit time or of these macronutrients or?
Absolutely, yes. So there's definitely a huge interaction between serotonin, the micronutrients, and then motility, the movement in the gut. So if things are static, you can develop not only microbiome changes and dysbiosis, which is the pathologic changes in the gut microbiome that can cause issues, but you can also have fungal overgrowth. So not just bacteria, there's archaea, there's fungus, and then also bacteria at the same time. And our gut motility and gut acidity is what protects that. So that whole environment is being protected by the acid we make in the stomach, the movement of the entire gut, including the small intestine, the colon, and you can develop bacteria that produce a lot of gases like methane, and methane itself can also then cause symptoms of bloating and distension. So all of those interactions are inherent, you know, in our patient population, and in any diseases, Crohn's even. Yeah. Yeah.
Two
Julie?
more quick questions. If is there anything to do in advance? Like if my son takes a probiotic, would he need to take that out of his diet or for a certain period of time before starting it, or could he just eat what he normally eats? Or
Yeah, I would keep. No, we won't change any of the standard care that they're on. So probiotics are fine. If we were doing the breath test method, though, I will say if we were doing the breath test because we're measuring CO2 and hydrogen levels in the breath, then yes, we would have to hold the probiotics. But for this transit study, we don't know. Yeah.
and then just because you've tried them before, does it just taste like a cookie? Is it sweet so he'll eat it, or is he going to be, because it's blue and he'll may think it's kind of fun, but is it taste
so.
okay? Okay.
Yeah.
It tastes like angel food cake.
Oh, he'll eat it. Okay.
Yeah, it's like angel. It doesn't taste bad. It doesn't like taste amazing, I would say.
Okay.
But yeah, exactly what Julie said. And I think they actually do like it because it is blue.
Yeah.
Yeah,
Okay.
you said. But yeah, that spirulina was green. It was like yucky green. No one's gonna have that. They were almost was like, we're gonna throw it in my face. So the psychiatrist in that clinic was just like, no, you can't. This is not gonna happen.
I have a question.
Sure.
My son's 27
Okay.
and has a very long history of GI and motility issues. He sees, for motility, he sees Dr. Samuel Nurko at
Oh yeah,
Children's.
the miracle of heaven, miracle of heaven.
And he sees Dr. Bowie for GI, and he's had all of these studies and tests. And as an adult, you know, the dysphagia started probably about 3 or 4 years ago. He has also been diagnosed with esophageal achalasia.
Okay.
But he's not a candidate. So we have lots of problems with vomiting, weight loss. His most recent GI endoscopy and colonoscopy, the way he described it is in his stomach. If you were to think about taking cold soup out of the refrigerator, just these globs of kind of fat. So they're thinking there might be some kind of an absorption problem going on. And because of the way his anatomy is, the way Dr. Nurko described it is, well, first of all, he doesn't think he's a candidate to have a surgery because first, his anatomy is funky, like one that he's not seen before. And because nothing's working, none of those nerves are working, he feels, you know, it could be worse than fixing the problem. So we don't know if we're going to end up on a GOJ tube again.
Okay.
He had one at the beginning of his year, you know, from 4 to 14. Then he was eating, and then all these problems, you know, started up again. But have you seen in kids as they've gotten older, either on the spectrum or other rare diseases, where there's this like progression of of these GI problems getting worse?
So that's a great question. You know, I only see adults. So Dr. Nurko, I know, is a pediatric neurogastroenterologist.
Right. And my son's an adult, but because children's doesn't kick them out.
Right. No, exactly. But right. Thank God. He's a really good doctor anyway. So yeah, so I think, you know, we don't know, but we do see achalasia and things like achalasia more in the adult world. So we see it with all neurologic symptoms, like not all neurologic diseases, by the way, like multiple sclerosis has achalasia, Parkinson's has like an achalasia type syndrome. So it's not isolated to actually any of the ASD syndromes. And so, yeah, so I think it could be a vagus nerve issue, but we actually do not know that for sure. And maybe that neuropathy worsens with time, but most patients don't get that, right? So it's still a rare condition. For achalasia, it's in 1 out of 100,000 patients.
Yeah,
So,
my son's a
but you know,
rare
yeah,
kid.
but, you know, your children are already right in that rare world. So who knows? You know, who knows if it's because of that? But I think that's why we need to vet patients better and, you know exactly what's happening with time and what is the etiology. But we see that in MS, we see that in Parkinson's, like all of these things, and those are a lot more common. Do you think, Sharon, do you think your son would be able to swallow the Smurf cake, or no? Probably not. With his,
Well, you know,
it is
over the last year, we've had a lot of issues. It really started with the increasing of vomiting, and you know, so he's mainly sustaining on. We have to thicken everything, and he's sustaining mostly on things like oatmeal, Ensure, scrambled eggs, and you know, when he does eat something like a bread or, you know, then he starts to choke. And I just get really nervous about aspiration.
Yeah.
And I think because he's had I mean, he had the pill with with the little camera, and you know, he's had really all of these
tests I talked about. Yeah.
He's been studied.
Yeah. Yeah. The manometry, I'm sure, all of that. Yeah.
Yeah. And they even, you know, used a balloon to try to open that sphincter twice. You know, we didn't have success. You know, so given that he's lost a significant amount of weight in this last year, you know, this is like the month that we're kind of deciding
what to do. Yeah.
Where we're going to go. So, you know, while I love the idea of it,
I
you know, I
tell you to watch what happens.
Yeah.
No, for sure.
Does anybody else have any questions?
Well, thank you guys. You're a great audience. Thank you for being on this call. I really appreciate it.
And before we get off, I just wanted to mention on the chat, Dr. Moshri, I went ahead and shared your email link.
Okay.
Your email address. So if people want to grab that before we sign off.
Make sure, Leslie, it's BAHA and then MOSHIR.
Oh, okay. So I'm going to go ahead and correct that. I missed that.
No, I'll put it on there.
Okay, thanks. So ignore mine. Below that, I also put in at 12:30 Eastern time, we have our SYNGAP 1 externally led patient-focused drug development meeting starting. That's a virtual meeting. I added the link on there also. If anyone's interested, it's free. Anybody who's interested can hop on the link. You just have to complete an access form, just your name and everything to, you know, be able to access the link. But we'd love to have anybody that is interested join us. But I don't want to leave before saying I think this is a brilliant study. And having been the manager for a program with children with autism and rare disorders at Texas Children's Hospital, I can tell you we had a lot of kids with intestinal issues and motility problems. It was, you know, you just felt so terrible because these kids really do suffer. And so I think it's great what you're doing. Definitely we'll be, we have it posted on our website, and we'll make sure, it, you know, I'll move it after the meeting to pop it up to the top so people don't miss it. So hopefully we'll get lots of people signing up, and really a great turnout. I think at one point we had 18 people on the meeting today. So it's really encouraging.
Thanks, Leslie.
Okay, thank you.
Thank you, guys.
All right, you guys have a good one. Take care.
Bye-bye.
Bye-bye.